we are going to discuss about pregnancy care and pregnancy care model. Now when you become pregnant, your midwife used to come to you and get yourself registered with the medical office of health. There is a MOH office in the local area. Then MOH will interview you and take basic information about you and prescribe some basic vitamins and then some blood tests. Thereafter, he will refer you to a specialist hospital to see by a consultant obstetrician gynecologist. In that particular first visit, they will again go through your history to find out whether you are a high risk patient or low risk patients. And if you are low risk, then of course they will put you onto shared care. That means you will be looked after both by your MOH and the midwife at local level as well as in special clinics at the hospital. But if you are high risk, for example, if you are complicated with blood pressure, if you are complicated with heart disease, or if you are complicated with increased blood sugar, and then they will have total care you at the consultant-led clinic. Now thereafter they will do routine tests, routine scans to date your pregnancy, and then at 20 weeks they will offer you anomaly scan, and then thereafter they measure your fundus or the tummy to find out whether baby is growing well or not. If there is a discrepancy between your weeks and the height of your tummy, then they will refer you back to another scan, and then you take you through the pregnancy up to 36-37 weeks, and then again your consultant will see you and decide whether the baby is going to be born by normal vaginal delivery or cesarean, and then they will discuss when to come, where to come, everything at this point. Now as you could know, now our antenatal clinic setup is made in such a way that up to 28 weeks, that means up to 7 months, you will be seeing once a month. Then from 7 months to 8 months, you will be seen every fortnight, and thereafter ideally you are supposed to come and visit your doctor weekly basis. Now the main concept of this clinic setup is that more concentrated clinic visits towards term. Reason being, because initially we didn't know that there are a lot of pregnancy complications that will develop later in pregnancy. But we didn't know that most of these complications that we can predict in early pregnancy. If you can predict these pregnancy complications very early in pregnancy, you can divide entire pregnant moms into two groups. At the beginning, if they are high risk, they can refer to a high risk clinic, but if they are low risk, they can completely put them into the normal clinic. Now, how we can change this now present practice? Now in Western world, what they are doing is at 11 to 14 weeks, at the time of that they do nuchal translucency, they look other things. First, they do the blood flow from mother to the baby. We call uterine artery Doppler blood flow. And by doing uterine blood flow, you can predict whether this mother is going to develop pregnancy-induced hypertension, that the blood pressure during pregnancy in late pregnancy, or whether she is going to develop the fetal growth restriction. That means whether baby is going to be small in later pregnancy. All we can check by just checking the blood flow from mother to the baby through uterine arteries. In addition to that, we can check some placental hormones, especially the thing called pregnancy associated protein A, PAP-A, and placental growth factor hormone. If you do all these two hormones along with the blood flow to the womb, you can predict these complications up to 80% detection rate. And the other main complication that we are really worried of, preterm labor. Preterm labor means you go into labor before completion of 38 weeks. And if you deliver very early, like in 30 weeks, the outcome of the baby is not going to be not very good because of the prematurity. But if you could measure the length of the cervix. Cervix is a structure where it supports the pregnancy. If cervix is weak, there's high chance that mother can go into early labor. But if cervix is long, that means cervix is strong, that she will not go into early labor. That also we can look at 11 to 14 week scan and say whether she is at risk of early labor. If she is at a high risk of early labor, we can use two techniques. One is we can prescribe her some progesterone hormone to insert through the vagina, and it will strengthen the cervix, or we can put a stitch to the cervix to make it strong. By doing these two procedures, you can prolong the pregnancy without going into early labor. Now the future of pregnancy care is therefore is going to be like you have very specific clinic visit at 11 to 14 weeks to look at the blood flow to the womb through the uterine arteries, and you measure the length of the cervix on top of the nuchal translucency, and then you can identify people who are at high risk of going into pregnancy-induced hypertension, fetal growth restriction, preterm labor. Likewise, there are a lot of things that you can do at 11 to 14 weeks, and who are when you do this screening test, if they are high risk, then you need to be managed under a VOG throughout their pregnancy, but most of them are going to be low risk, and low risk mothers, even they don't have to have that much of clinic visit that we used to see, like every week after 36 weeks. That we don't need that, because you know that the patient is low risk by initial assessment, and they can be managed with the normal clinic setup.